Okay, great. So is everybody okay seeing my screen?
Yeah.
Perfect. All right, great. So actually, no, I think I didn't start on the first one. Okay, so I'm going to be talking about survivors teaching students, which I have been with for 9 months, and it's the Ovarian Cancer Research Alliance that organizes this one particular program, which has almost 1,000 volunteers, survivors that run it, which I think it's really cool. It's been offered in over 344 healthcare places. It's in tons of states and even in some other countries. And I got involved with this pretty soon after my diagnosis. Let me just go to the next, sorry. So yeah, the goal of the survivors teaching students is to increase the number of healthcare providers who recognize the symptoms and risk factors for ovarian cancer so it can be detected earlier. And I got involved with this soon after I was diagnosed because I was diagnosed waking up from what I thought was cyst surgery to find out that I had ovarian cancer, and it was the same cancer that my grandmother had in 1988 when I took care of her and lived with her when she had it. And the prognosis is really about the same as it was for her, my prognosis. And so the long-term survival for stage 3 and 4 people is still pretty poor for ovarian cancer. There have been some advances, especially for people who have the BRCA gene, some PARP inhibitors and some new drugs that have increased that some. But since most people are diagnosed in a late stage with ovarian cancer and the majority do not have the BRCA gene, the prognosis and the outlook is still pretty poor. So part of the reason I wanted to get involved is I was kind of shocked, to be honest, when I first found that out. I couldn't believe. I remember when my grandmother had ovarian cancer and we were like, just hold on for another week or month, because there's got to be some breakthrough in some clinical trial. And we were so hopeful and desperate and waiting. And just the idea that 4 decades, well, three plus decades later, and all those clinical trials and all those people who've participated, that more hadn't changed, was discouraging. So I wanted to find a way to channel my rage and try to turn it into something positive. And I ironically had been a patient advocate, but for post-traumatic stress disorder and in the mental health realm. And I bring that up because with post-traumatic stress, the narrative's really changed. And the idea, so, before when I used to refer to myself as a survivor, I just meant like a trauma survivor. So now I feel like I'm a survivor squared, but I learned a lot of lessons in advocacy around mental health and post-traumatic stress disorder. For example, PTSD, when you used to Google it even 3 years ago, you'd mostly see white men and veterans coming up because the main narrative of post-traumatic stress was that it was something that happened in combat, which it absolutely does happen in combat. But the majority of people with post-traumatic stress disorder are women and children, and it's a result of childhood abuse and domestic violence. So the kind of mass perception is that it's something that happens during combat, when that is true, but it's not the only time that people get post-traumatic stress disorder. And so there was about 5 moms, and we launched a Faces of PTSD campaign, which was great. And people just shared all their pictures of PTSD. It got some good news coverage. And we were just trying to say there's more to this disease, and more people need to know about how people get it and how it's treated. And then also there's a large advocacy community with trauma survivors, because in the late 1980s, when PTSD made it as a diagnosis, it was again initially for combat veterans, and there wasn't as much understanding about complex PTSD or CPTSD, or what's also referred to as developmental trauma. And also, what was the evidence-based medical model was basically medication and talk therapy, which we now know is actually terrible for post-traumatic stress, can actually make things worse. So for good or for bad, when I came into my ovarian cancer diagnosis, I had a high distrust of the medical system, a high trust of survivor perspective. So my first thing that I wanted to do was I just wanted to hear from other people that had ovarian cancer, how they managed it, what happened, and just what survivors felt like were the best treatment options, and what survivors felt like were the best clinical trials, and what survivors felt like were the best hospitals and doctors, et cetera. So in some ways, I'm very grateful that I had this background and experience, because when I was diagnosed with ovarian cancer, it took me a long time to find my voice in this other realm. But immediately when I was diagnosed, I did have the ability to advocate for myself. I was very grateful for it, but I also was a little bit dismayed where current treatment options are for people with ovarian cancer. So the survivors treating teaching students program, I really liked, because I was learning basic information about ovarian cancer, my own, but also just other types of ovarian cancer. And I really liked this model because I'll show you a little bit about it. So kind of becoming an OVCA advocate, it was really straightforward and it was really easy in the beginning. You know, you just contact them. They immediately give you access to a database with tons of information, both about ovarian cancer, but also about advocacy, how to tell your story. They share information about surveying students. There's a facilitator who leads the program. So as a brand new advocate volunteer, the only thing I had to do was agree to share my story for 7 minutes with students, medical students, and be one of 3 survivors sharing our story. And then there was a facilitator who's a survivor. And when I say survivor, I also mean it could be a family member that has had somebody in their family with ovarian cancer, could be an advocate. So I'm just using that in the most broad sense. So the facilitator that we have in the Northeast region, she lost her mom to ovarian cancer very suddenly, and got really involved. So she facilitates, and a facilitator on one of these calls just shares about 20 minutes of basic information about ovarian cancer, how it's diagnosed or misdiagnosed, a little bit about symptoms, kind of where things are at. But then 3 survivors share our stories about, and we really focus around how we were diagnosed or how our diagnosis was missed. So it was really clear and kind of a very direct formula. We get training as volunteers. We get help. We get to see the trainings before we go do one live. We get a little bit of help with public speaking if we're not used to that. Some people get help with writing their story if they haven't done that before. And then we get to attend some live trainings and just see what it's like. Is this for us? And then you can sign up to do, you know, as many or as few trainings as you want. Some people do 1 a quarter, some people do 1 a month, some people do even more than that. So it really is it's just a great way to meet other survivors. It's a great way to educate medical students. And I just love the program. And it's just a very good beginner kind of advocacy work. I think it helps expose you to organizations. And then if you want to do more, OVCA, as well as other organizations, do lots of policy work. I know Kim Richardson has a Survivors Teaching Scientists program, which is like a bi-directional program in Chicago. And that is fantastic. And I've learned a lot from them, and they have YouTube videos. So this is definitely not the only kind of survivor led program, but it's the first one I found out about and really liked. And it's a entryway in for people that want to find out more. And then also, like this group, expanding to find out about other types of cancers as well. But for OVCA, it's focusing on ovarian cancer and the many types of ovarian cancer, because there are many. So really the training is really, the format is super consistent and the focus is very specific. And I think it makes for an effective 1-hour presentation. It's always done the same way. I don't usually like formulaic stuff, but in this case, I feel like it really works. It's just, it's always effective. It's always different. It covers the same basic information. And then whatever 3 survivors are on are sharing slightly different things. You know, we've all been diagnosed at different ages, stages. We had different symptoms. Some of us have recurred, some haven't. you know, some of us are early stage, some late stage. So it's a good range of survivors, and we're always a different group on every call. And the focus is really what's most relevant to medical students. What can we help what can we humanize for medical students about the symptoms, about the lack of screening and detection and treatment that exists, and about the importance of listening to patients, because for any patients, it's important to listen, but it's especially important where there aren't any screening tools. And so ovarian cancer doesn't have any screening tools. So listening is especially important, and just listening that even if the symptoms are seemingly common, like bloating or urinary frequency, people don't come to the doctor if it's uncommon. If it's a common symptom to them, they don't typically come to the doctor. So just listening, when someone comes to the doctor, it's usually an uncommon thing for them. So just stuff like that we'll focus on. And the slide deck is pre-planned. So the facilitator, if you wanted to volunteer to become a facilitator, you also could do that. And then you're given a slide deck, and you're sharing everybody is sharing the same information about the factual aspects of ovarian cancer. So just some of them: number 1, gynecological cancer deaths, 5th cause of cancer-related death in women, 11th most common cause. And then just, you know, a little bit about the stats of how many people will be impacted and diagnosed in a given year. And then we go over the same things that I was saying. What are some of the symptoms that people have? Bloating, difficulty eating, pelvic and abdominal pain, urinary frequency. And we will, when it's survivors talking, share about our own and how they presented. And then we'll just remind the students that there isn't a test for ovarian cancer. There are some tests that can help you, know if there may be a tumor marker, CA-125, but it's not reliable because it can be elevated in some people without ovarian cancer, and it can be low in some people with ovarian cancer. So it is more useful in the recurrent setting, although not 100% in that either, but that's some of the types of stuff we share. We share that only 15% of people with ovarian cancer are diagnosed at an early stage when it's most treatable, and that most of us aren't diagnosed until we're stage 3 or 4. And also 75% of us are misdiagnosed with something else first, like IBS, UTIs, menopause, stress. So for me, that's an important point, and it's really why I love being part of this organization, because there's a lot of great awareness campaigns that are directed at the general public, but the truth is survivors already go to the doctor when we have symptoms, and it's the medical providers also need training to understand what those symptoms are, because we in fact already do go. So the idea that we don't is kind of a misnomer. It's just that it doesn't always get a diagnosis right away. And in terms of being a medical provider, there isn't a test. There isn't an early intervention test. So it does make it difficult to diagnose this disease. So then we just talk a little bit about some of the protective factors for ovarian cancer, what can be protective. And we also share, what are some of the risk factors for ovarian cancer, and just letting medical students know that. And then the facilitator, whoever the facilitator is, will go over what types of exams should be performed if you at all suspect ovarian cancer. For some people, it's surgery and a biopsy, which will confirm it. You can get an idea that there may be ovarian cancer, but it's not easy to diagnose and have it be confirmed outside of surgery. Even with after an MRI and a transvaginal ultrasound or a CT, you may see something may be seen on the scan, but even as my surgeon said, until we get in there, we don't know it's cancer. So basically for me, it's all about stats and stories. I feel like whenever sharing information or learning information, some people really respond to stats, some people respond to stories, some people need both to remember something. So I really like that it combines both, and how much we choose to share with students. is varied. And so some people share a lot, some people share a little, and that's fine. Between us all, we cover some basic information and then we humanize it. So I guess that, yeah. And then my daughter also is a senior in high school and becoming a medical student. So maybe that's part of the reason why I did it too, is it really, I love that idea that, like she said to me, I wish I could go to medical school sooner so I could cure you, so I could save you. And I hope to try to make medical students passionate and just remember that this is a disease that, like many, needs more attention, needs more focus, and we need more genius, and you know, just hoping and encouraging medical students to learn more, and maybe somebody will do something amazing. So that is that. So I'm happy to take any questions if anybody has any. And thank you for letting me do this, because I have not done this presentation before. I'm kind of new to this. So I was honored to have this chance.
It's fabulous, and thank you. And I know it's even more challenging when kind of your own personal story is intertwined in it. So well done.
Thank you.
So I actually have a question, and it goes back to kind of the original slide and even some of the information that you sent. And it's around that, you know, it's a registered trademark, survivors teaching students. And so my question is this Ovarian Cancer Research Alliance program, or is this a bigger survivors teaching students program and you came into it through the ovarian cancer?
That's a good question. I only know of it through OVCA.
Okay.
So I don't know if other people have the same, like, yeah, they, I don't actually know. I know there's survivors teaching scientists. I know there's other similar programs. I don't know if this model is something that is applicable beyond ovarian cancer. That I don't know.
Well, the model's applicable. It's just wondering if it's available too.
Yeah.
It's a beautiful one. John's being all official and raising his hand.
I am following protocol, as my mother taught me. Thanks, Cissy. I had two questions. Based on what you have experienced as an educator to medical students, and kind of what you've gleaned through being involved in this, what's the nature of the Q&A of the medical students? Are they hanging on or saying thank you to the speakers, and it's more kind of that they're processing it? Are you getting the tough questions
yes.
about mortality, about sexuality, about freezing eggs for younger, or do you sense that it's just washing over them and perhaps they take away something really good?
That's a really good question. And sometimes they're really quiet, and it sometimes depends on, like I always put in the chat, ask us anything. That's why we're here. We really want you to ask. Nothing's too personal. Like just basically trying to remind them that like, that's why we're here and there's nothing too personal. And we do try to say some of the hard things in our, you know, like some people had bowel issues or urinary stuff that is not comfortable, and we don't always talk about, that is part of this. And so we will try to work that into our talks, and we kind of go over the top to invite people to please ask us questions. If some of the teachers or some of the students have family members and have had experiences, and once one person leads it and opens it, it blows open. But sometimes that doesn't happen. And sometimes if it's really quiet, we survivors will ask each other a question just to get it going. And somebody will open up, and that usually is enough. If somebody opens up and kind of seems comfortable doing it, and then you get a bunch of head nods. But it's been really interesting, because one of the students, like I put it on here on this slide, said, I've treated plenty of people with ovarian cancer. I've treated their symptoms, but I've never heard one person speak about their diagnosis, how they got diagnosed, what it was like, the impact it had, the course of the disease. They're really focused on the symptoms that they're treating for that particular patient in a moment in time. So that also is helpful as a survivor to hear, like, they see all these people and they're seeing people and symptoms always together. They don't always have that story, the wider story. And that is probably the one thing we do get feedback, which I also really like in the surveys. What was the impact of this style of experiential learning? What would you change? What didn't work? What was confusing? So people do say really nice things, and we hear if they don't as well, but they do say it's memorable, or they learned things they didn't know, especially about the importance of somebody knew something was wrong. They didn't know what, but they knew something was wrong, and they wished, you know, so they're just more aware of, okay, you might have to explore and consider more than originally seems like you'd need to, because the symptoms are fairly benign. If, you know, and it is easy to understand why people assume it's other things, but it helps them remember it isn't always UTIs. A lot of us have had UTI or IBS diagnoses, so when they hear that as well, they're like, oh, you know, like that definitely gets their attention. So, and a lot of them have their own families that have had different things. So, you know, we will talk about BRCA genes and other types of genetics, and they are really interested in that as well. I would say that is a very big topic of interest, at least with the students on the Northeast and the schools that I've done. I've only done regional stuff, so I don't know if it changes depending on where the location is.
Thanks.
And they've been all virtual because of COVID, but typically you would be in the room with
Yes,
people?
we would typically be in the room. They've actually picked up in number though. The virtual format has allowed for, I don't know why, some people are doing more of them. So we actually we have more scheduled, and because so many survivors are having their own health issues, sometimes it's easier to just commit to the hour versus the 3 hours it would be if you're driving in somewhere. So it's been interesting. It'll be interesting to see how that changes when it goes back.
Cissy, this is Lee. I'm also a volunteer with that program and agree with you. First of all, thank you so much for doing this presentation, and agree with you about how rewarding it is to be a survivor and really tackling the satisfaction and the feeling of you're doing something useful to tackle a problem that's very specific to ovarian cancer, where it's diagnosed so late and the symptoms are vague and is often misdiagnosed, and the ability to walk these med students, nursing students, you know, through a sequence of your symptoms in a way that makes them really think, I think, and focus on how to, like, basically not on my watch. Nobody is gonna walk out of here after this presentation with ovarian cancer and I tell them it's irritable bowel syndrome. You know, that will never happen to me. And I think the surveys they do a survey before and after about the symptoms of ovarian cancer, and they measurably show an impact. And that's my understanding is one of the ways how they get funding. Right, is they can demonstrate an impact in learning of these students. But anyway, I think it's fantastic. And thanks for doing this.
Do you know then the answer to the question whether or not this is the program itself? Has it already been expanded to other cancers, or it just is in?
My understanding is it's just for ovarian cancer. I'm not sure exactly why it's trademarked, but I'm pretty sure they trademarked this as a way to protect the material. But I don't know what the like if other organizations wanted to adopt it. I have no idea how that works. But
yeah, and I certainly would never encourage anybody to violate a trademark, registered or unregistered. It's just, you know, I know that ovarian cancer in particular is billed as kind of this silent killer because there is no screening. And at the same time, when we look across cancers, if you're 22 years old and you're having bowel issues, guess what? You could still have colon cancer, but you're disregarded. And so, Cissy, when you're talking about sharing that personal experience to a future doctor and saying, this is how I was dismissed, that is so powerful, because whether or not they're seeing a woman that might develop ovarian cancer or a man that doesn't have ovaries and will never get ovarian cancer, they've gotten the point that being dismissive is not only dangerous because there can be something really wrong, but it's how it makes you feel. And that is why I as soon as you started to describe this program, I think it's so powerful. And I think that there's application for it in every cancer in some way, shape, or form, and in really every doctor-patient interaction around what it feels like to your point, when you go to the doctor, it's because something isn't normal for you. And yeah, I just think that's a really, really powerful, message and a really powerful structure that's around this.
And one of the things too I wanted to add was, you know, I have this picture of me and it's, you know, a bladder and a tumor, and this was completely missed. I was discharged from a hospital having a cantaloupe-sized tumor. They just looked quickly and thought it was my bladder, and it was the bladder was squished and that was the tumor. And so even with evidence, I was discharged as having a stomach flu. And I wouldn't have known that, except my surgeon said, it was on your first scan, because I had subsequently, you know, 4 more scans before it was found, because it had been missed. And she's like, it was on your very first one. And so I do share that story, but I also share that I worked with that hospital to change their policy and process, because 75% of radiologists are men, which I didn't know. And it was a pelvic and abdominal CT. And they just forgot the pelvic section. They didn't even include anything, you know, when they do all the spleen, normal, abdomen, whatever, they didn't do the pelvis area at all. I thought I was missing a page when I got the printout report. They just skipped it. And so now every radiologist had their own form of screening. Now they have a system and a form for every radiologist. And if it's a pelvic CD, they have to know what the ovaries, uterus. But I mean, it was shocking to me that wasn't normal, and that every radiologist used their own technique and had their own process. And just, you know, like my aunt joked, did they just put a cup of coffee down on your bladder on the image and just see the thing underneath? You know, like, how did it get missed? But also, people are human, and there's a certain amount of human error. So I do share that, not to shame the place I went to, because the head of radiology at that place, we ended up working together to change their entire process, which I'm extremely grateful for. And that is better than an apology for me. I mean, that is going to change things. So it's also to remind students to collaborate and be open to changing systems, because it's not just about one person being misdiagnosed. When 3 out of 4 are misdiagnosed, that's not an individual issue, that's systemic. So how do we think about it differently, beyond just the patient in the office, and like what systems make this, you know, so it's not silent. And that's what I always remind people too, is that any cancer that doesn't have a screening would be a silent killer. You know, like none of them are screaming or saying, you know, coming with alarm bells to announce themselves. It's just, there's other ways for them to be caught. If they're screened for, which also needs to happen, as you say, with all cancers. So that's why I love being part of this group, because I also learn what is unique to ovarian cancer, but also what is not.
I have more questions. Does anybody else have any?
As a former reporter, I have to have one more question, if I may. It's Allison Rosen, who was part of this community and who you all know or know of, I recall talking with her pre-pandemic when she was still at Baylor about the med ed of the patient, and Lee touched on this some in terms of the impact of patients addressing students in some way. Does that make them better doctors? Do they more empathetic? How do we measure effectiveness? And I recall talking to her and just riffing and her saying, I'd love to talk to people, and she was at Baylor, so she was obviously in a unique position as a cancer survivor and a curriculum developer or whatever her title was as a professional. So she played that role. But again, getting back to that, nice to have, here comes the lady with breast cancer or lung cancer talking to this group, and then out they go, and I hope for the best. Good luck in your careers. Is anybody, either you, Cissy, or anyone, is there any way, because Allison's like, my dream is to like get everyone like me and be able to create that curriculum so it's more measurable, more demonstrable, and to do it right. If what this OCRA program is good, could it be better?
Yeah, I mean, I'll also defer to Lee, who maybe knows more than I do because I'm newer with the organization, but I do, it does feel satisfying, like it is making a difference. It doesn't feel like in the trauma survivor world, there's a lot of public speaking, which can feel like what we call survivor porn. It's like, give me your sad story and how you recovered. And it's very specific. Exactly. And then you're out, but you're not part of programming. You're not part of changing anything. You're not part of setting the agenda. It's like a very specific story that it was bad, I was saved, I got better, now I'm good, whatever. It's just very specific, and it doesn't allow for a lot of complexity or nuance or co-creating change, or even just defining the narrative. Like, I never refer to myself as a patient, or like, I don't think of myself as a patient. I'm just a person who sometimes has this medical issue. Like, even just the way we refer to people is different if we're the people than if we're talking about those people. So I do feel like it makes a difference. I haven't been with the organization long enough, but I would be interested in knowing if they have summarized, or like, how long has this program been in existence versus have there been any changes in diagnosis or less numbers of misdiagnosis or anything like that. I don't know the answer to that, but I think it would be important to get that data, as well as it feels like it's making change.
What I was told is the way they measure success is they administer a survey at the beginning of the presentation. And then the presentation is, like Cissy was saying, it's very highly structured, and with going through different symptoms, and then patients tell their stories. And then there's a Q&A at the end. And then during that, they offer a follow-up survey. And they, at least if I'm recalling correctly, there was something like a 20 to 30% improvement of knowledge of early symptoms of ovarian cancer between the initial survey and the follow-up survey. And it actually has been around a lot longer than 2019, Stacy.
Pulling stuff off the website.
Yeah, OCRA has been through many mergers and iterations, and so I'm not entirely sure how all that fits together. But one thing I will say, so I just did one a few weeks ago to some nursing students, and with 3 other survivors and a very experienced facilitator who kind of runs the show here, bless her, in Seattle. And she, one of the things that I thought was most compelling at the end of that, and I can even read you some of the comments that were shared from the evaluation at the end of it, is that people, all of our symptoms were very different, and our stories were somewhat different. Like, some of us had bloating and ascites, and some of us had early vaginal bleeding or whatever. We're all diagnosed at different stages. But what these students came for, and you really heard them grasping for and coming to understand, is like, well, how do we know if there's something persistently wrong? Do we know this because these symptoms, they get worse and they don't go away, even if they're different? here's some of the comments. How has the presentation changed the way you think about ovarian cancer? To act fast and look beyond the obvious. The presentation helped personify the symptoms and the risk factors of ovarian cancer. Moving forward, ovarian cancer will be part of my differential diagnosis for individuals who exhibit symptoms or have risk factors. It was extremely informative, and I was more likely to investigate vague but persistent symptoms. We had this whole discussion about, one of the things in ours is about, how providers make decisions. And so, for example, you look for horses, not zebras. But if you're the zebra, you're in trouble. You're down there at the bottom of the list, and ovarian cancer is a zebra. I mean, it is. So, and that was part of the paradigm. And then the other was that doctors tend, one of the conversations that was interesting is that in one of the stories was that this person was being monitored for breast cancer and as was my story actually, breast cancer and uterine cancer, still missed with a late diagnosis of ovarian cancer after multiple misdiagnoses. And part of the problem was it was looking for symptoms of uterine cancer, but the focus was narrow versus stepping back. And so what it did is it started engaging some of these levels of conversation, which I think really made the difference. And you actually watch the students grasping to understand what happened. And oh my gosh, I can't believe it moved that fast. And, and it was a level of an interaction and connection that I think is pretty rare, I would think, in a medical school. But
I would think too that this program is very specific to screening and the kind of conundrum with screening and hearing the individual. But these are smart people going to med school, and I'm sure that they have the ability to then extrapolate that and say, again, in cancer, outside of cancer. But what you said, Lee, was really, again, very powerful, is that they are functionally taught to look for horses.
Right.
And so if it's one thing, it's ovarian cancer, but I think these people can see that, we do need to leave some room for the zebras, for the rarer, like, what if, especially if somebody is coming back again and again with the same kind of complaint. But also kind of the allegory to that, I know we've been talking a lot about like side effects and being dismissed, like, oh, that's not part of what the FDA lists as a side effect, right? I mean, again, that would be a zebra side effect. So I just get really excited about a program like this. Again, not saying, anybody's going to steal from what the Ovarian Cancer Alliance is doing, but this model of helping these people form their personal stories and their experiences so we can go back and not shame people for what they did wrong, but teach the next generation for how we might do things differently to have better outcomes. And Stephen, not to call you out in particular, but pancreatic cancer is another one that is just renowned for people don't get diagnosed with pancreatic cancer until it's really, really, really bad.
I've been waiting here. So that there's a program that I'm involved with at Weill Cornell. It's also run at Columbia, U of Penn. There's a few other universities that run it. So it's very similar to what Cissy has been talking about. It's called LEAP. I got to read the acronym here. Longitudinal Educational Experience Advancing Patient Partnerships Program. And so what that is, there's a group of us that are all patients. We get assigned a number of medical students. Their first year, they follow us through all 4 years. So I have a nurse practitioner following me, a physician assistant, a med student, and an MD PhD student. And they'll come, if I'm coming there to get a CT scan or for a consult or whatever, so we'll meet before. I invite them to come in on the consult, sit in on that. We have conversations probably every couple of weeks. And I've had conversations that have gone on for 2 hours. And so talking about misdiagnosis, the person that I found that had the pancreatic acinar cell carcinoma, I was asking his story, and he was found, he was stage 2 only because the tumor was larger that put him into category 2. Most people with pancreatic cancer found stage 3 or 4, which was my case. And I just lost my train of thought here with the, he had a surgery, he had a distal pancreatectomy. His lymph nodes, it took 22 out like they did mine, and they were all negative. So the tumor board met, and the tumor board, I met on 2 occasions. On one occasion said that they suggested he take chemo as a preventive measure. And then they met again and they said, no, your lymph nodes were clear, you don't need it. And so I think the paradigm really needs to be changed when you're dealing with such an aggressive and lethal disease. And nobody ever said anything and explained to this guy about minimal residual disease, microsatellite cells, circulating tumor cells. And of course, I knew that, and there was no way that they were going to say to me, no, it's okay, you don't need chemo, because I was going to insist on taking it anyway. But these other people, they don't want to take chemo, so they're happy to hear he had a second opinion, and it was, now you don't need it. And he probably should have gone for a third opinion. So long story short, he ended up progressing with the disease, and now he's stage 4. They gave him a PARP inhibitor because he had a BRCA mutation, but one of his tumors is not responding to it. So he's got to find a clinical trial, and all of this probably could have been prevented if there were some forward-thinking oncologists that said, well, you know, to be on the safe side, it'd probably be a good idea to take the chemo. And I wonder how many people are in the same boat that he is, that, you know, it could have been nipped in the bud if they thought outside of the box, where a lot of these oncologists, the older ones, it's a textbook. We'll give you drug A. When drug A stops working, we'll give you B. And then when B stops working, we'll give you C. And, oh, we're out of drugs. Yeah. So I'm trying to get the point across. You know, they need to start thinking differently, get out of the comfort zone, think outside of the box here. It's a whole new world.
It's really interesting that you bring that up, Stephen, because I know, and just looking at who's on the call, and hi to you new people who joined us, in the breast cancer space, we're actually in a very different space, which is when you're diagnosed with breast cancer, especially when you are younger, they want to throw everything at you. And so we've worked really hard to say, yeah, we could do that as a just in case, but is that actually going to be helpful, or is it going to be more detrimental to me as a 32-year-old and then have to live with the side effects? And so I think you bring up a great point, which is, again, sharing these personal stories and these experiences really, I think, sends the message that every individual is different, right? So that thinking out of the box is really important, and the whole one size fits no one. Hi, Barbara. Hi, Tamara. I don't even know what time zone you're in.
Hi, everyone. Sorry to join late, but I got part of Cissy's presentation. Great presentation. And if you give me a minute, I wanted to make a comment to this group. I was participating in it was a meeting. They're developing the new kind of roadmap for clinical trials for 2030, and it's the Academy of Science, Engineering, or whatever. It was a big deal when I received the invitation. I said, oh, seems like I'm important. Anyways, the thing is that I was talking and they were saying what should be, this part was about resiliency, transparency, and sustainability. And moderate, there were 2 other in my session, and they wanted me to concentrate in sustainability. And I, concentrated in the patient. And I said, you have to talk to the patient, educate the general public in terms of what is clinical trials, and not people have to find out about clinical trials when they are confronted with a disease. So people should be talking about clinical trials all the time, wherever you go. So it comes common when you have a disease and you will be able. So what they're pushing is trying to have it kind of a part of the patient care. But then afterwards, we had a kind of a network session, you know, old people like me don't know, but it's called Gather. And it was so fun or whatever. But anyway, there was this guy, I think he's a physician or something. And I was continuing to say how important it was to talk to patients, because when they were talking in the meeting about involving the community, researchers think about community-based participatory research. And I said, it's not that what we're talking about. It's talking that you talk to people who have the disease and they can tell you how do you run your trial, what we need, what will make it better. So when I was talking to this guy and he says, yeah, but where can I find people like you? And I said, there's a lot of people like me. So I was talking to him and I think what we have not done good enough is to go to, like, you go to the universities or to researchers or whatever for people to know there are people. And I even talk about this group and I said, right now we have a group of people of different cancers that we're getting together. And we, if you talk to me and you need someone from lung cancer, I know I can go to the group and we'll find an advocate for you. So he got my information. But what I wanted to say to the group is that we have to keep doing things for people to know that we exist and the impact that we have in research, in their outcomes and everything else. So thank you for the opportunity just to, I can never be here and be quiet, especially only the last 10 minutes or something. So
we don't want you to be quiet. It's good to see you. And Tamara, I thank you for turning your camera on. What time is it there?
It is 8 a.m.
Oh,
so I'm so excited that I could join. Usually you guys are meeting like at 2 or 3 in the morning, and I'm gonna still try to join, but sometimes it's difficult. So we'll try to fix that. I think again, I'm just trying to get my head around grad school and get that going. But then we'll try to do like once a month a time that is going to work for you and for Rod in Australia, and I know Lalani in Australia. So anyway, Gina, I see you too. Just recognizing
Hi
you.
there.
Hi. And I want to be really conscious of time. We've been on for an hour, and so I know that it's late for some of you. But if you have any final questions for Cissy, this was fantastic. And you know me, I see where you show me something that's very specific, I see opportunities to make models like that elsewhere. And so I'm hopeful that some of you see that in your spaces, and that maybe we can kind of strategize about how we take this larger concept and make it more widely available.
I wanted to add one last thing was one other actionable thing that I think is really important is that we do share with medical students, depending on what they're going to be, is that for ovarian cancer, if a person is a doctor and in a position to refer somebody, we let them know the stats show getting a GYN-onc is, makes for far better outcomes. And that is also, if that's all we did, I feel like that is really important because a lot of times, like me, you think you're going in for a cyst and then it's a staging surgery. And that's very different to be done by an oncologist surgeon versus not. So that is another, so what I really appreciate about the program is how targeted it is to knowing the audience. The audience is medical students and medical people. And so anything we share is really specific to that. And I think that also helps the chances that it will get remembered. And it feels very specific for, a big disease. It's like something very specific and tangible and concrete. So that is nice. And I think the simplicity is applicable to all different types of cancers. And I've learned so much tonight on this call. So I love these meetings.
Thank you guys. Thank you all. It's wonderful to see you. It looks like we're not going to meet next week. So we're going to meet on the 8th at 10 a.m. and or 2 a.m. depending on where you live. I'm sorry. But then we also have, for those of you who are on Twitter, there was a radiologist who is actually a student, and he, as part of his education, has actually been helping teach others about radiation. He just had a brand new baby, and so they're kind of in that like little tiny family unit, getting to know each other. But mid-April, he wanted to reach back out and maybe set a time. And so I'm not going to hold him to the 10 a.m. time. He might just be another special session, like we've done with some of our other guests. So I will let you guys know more about that. And I did rage quit on Twitter. It was a little ugly last week, but I will get back there. But otherwise, I'm totally on the Google group. So if you have anything to share with the group, please send it. If you don't know how to do that, you can just send it to me and I will share it. And that's it. Sending all of you guys good energy for the week, for 2 weeks. Bye.
Bye, everyone.
Thank you.
Bye.